gonna hit that now. And welcome you to tonight's event. So as I say, thank you all for being with us for our August Health Inequalities lecture. And we're really excited to have Andy Bell with us this evening. Andy is the CEO for the Centre for Mental Health. And I think we're really pleased to be having a very important discussion about mental health this evening, about the differences in opportunities, differences in ways that people are treated, these inequalities, and how these can really affect people within our communities and lead to mental health challenges. So really delighted to welcome Andy. Andy, over to you to start us off.
Thanks very much. It's really nice to be here. I'm aware there's a slightly bigger event happening in Brent today because I came through Wembley on the way home. So lots of things going on locally. Thank you for coming along today, and I hope this will be useful to you. If it is, please do follow the work of Centre for Mental Health. I will try, if I am capable of multitasking, of sharing in the chat a link to our website and how to sign up to our email bulletin. So if you like what you hear, please do follow us. If you don't like what you hear, then at least you don't have to hear it again. So that's something. So we're Centre for Mental Health, and we are a national charity. We're completely independent, and our work is entirely focused on tackling inequalities in mental health. And what we mean by that is both the social and economic inequalities and injustices that mean some people have a much greater risk of poor mental health than others, the unequal treatment of people within the mental health system by a number of different dimensions of inequality, and the unequal life chances experienced by people with a mental health difficulty. And I can talk about any of those during the conversation. So I think I've kind of allowed about 15 minutes to introduce, but hopefully the most interesting bit of this event will be when we have a discussion later. And if there's anything on any of those topics you're interested in, please do ask. What we do as an thank you. What we do as an organisation is predominantly research, but it's research with a really clear purpose. So we're not an academic body. But the research we do, the evaluations we carry out, the evidence we collect is really done with a view to influencing policy, changing practice, bringing about social change, influencing national and local government to do things differently and better. We, among other things we do, have a network for people who work in or are elected members of local councils. So if that's you, please sign up to the Mentally Healthier Councils Network. I don't have to share a link to that, but I will make sure I share a link to that during the conversation. And we also focus on a number of other areas, so including children and young people's mental health. We host a 300 organisation coalition focused on children and young people's mental health across the country. And we also have a focus on physical health inequalities affecting people with a mental illness, an initiative we call Equally Well, which is about ensuring that we reduce the life expectancy gap for people living with a mental illness. So that's a little bit about us, not because it's the most interesting bit of the conversation, but because it gives you a sense of where what I'm going to tell you comes from. So this is all based on research. It's all based on evidence of different kinds. And our work is solely about using evidence to bring about change. We're not a service provider. So we're not trying to kind of direct you to a particular kind of service or intervention. So I suspect that many people on this call will have knowledge, either experiential or professional, around mental health, but I'm not going to make any assumptions. I'm going to assume this is a topic that you're interested in, but may not have a particular kind of knowledge from education. So if this is useful, I hope it will be. But when we think about mental health, the important thing is to start with, well, what do we actually mean? What is mental health and what is mental ill health? And unless we understand that, we're never going to get to the beginning of the conversation. So when we think about what either harms or creates good mental health, we need to imagine all of us on a spectrum. If I was doing you a really boring PowerPoint presentation right now, there'd be a slide with a little spectrum running from green through to red. I'm not. So, phew, that's something, isn't it? You're not having to sit through some boring PowerPoints. But if I was, you would see a line that runs from green through yellow, orange, and red. And you can roughly divide all of us, every single one of us, all of us here on this call today, all of our families and friends, and all of us throughout our lives into that different parts of that spectrum, reflecting what our mental health is like at any given point in time. So we all have mental health every single day of our lives, from when we're a little infant to the last day of our lives. And hopefully for most of us here, our mental health is relatively good at the moment. Not everyone's will be, because we know that 1 in 4 of us over the course of a year will experience mental ill health. And that, of course, means if you think about the average life cycle, most of us will spend some time in our life experiencing mental ill health of some degree or severity or another. Not necessarily all of us, but the vast majority. For many people, it will be short-lived, and that's good. But for others, it will be for a very large part of our lives, particularly if we have an ongoing mental illness. But again, you can have a mental illness, but on any given day have relatively good well-being. So your mental health may not be all that bad, even if you have a diagnosis, if things are good for you. But many people will be in an in-between area where you might not have a mental illness right now, but you could have risk factors that are putting your mental health at risk, and you could be just about coping or struggling. And so what we want to do, if we want to create a mentally healthier society, better mental health for all of us, we have to think about things that you can do at every stage of the spectrum. If someone's got good mental health now, that's great, but what can you do to stay that way? If someone's struggling with their mental health, but not necessarily unwell, they certainly don't need a clinical intervention, but there may be ways in which you can provide support. For example, if money worries are the cause of struggling with your mental health, if you support someone to maximize their income, have enough money coming in, deal with problem debts, and other, if you like, economic and social factors in their life, that might improve their mental health so they never experience what you might call mental illness. And if someone is very unwell with their mental health today, again, there are types of treatment and support that can help people to recover their lives and get back to good mental health, sometimes, or at least kind of good functioning in their life. So the way we think about this from a kind of public health perspective, and I'm not a public health physician, I'm just a layperson who's learned all this stuff over the years. We think about risk and protective factors, and this is quite a simple idea: is that our mental health isn't about us as people. We're not born with good or poor mental health, and very little of what we know about what affects our mental health is genetic. So we're all of us got the potential to have good or bad mental health, and so the risk factors you've got in your life could make it worse, and the protective factors you've got can help to boost it. One obvious protective factor, for example, is having a good attachment as a baby. We know that can make a big difference to someone's life chances. And so a good start in life is a really strong protective factor. So is having enough money coming in, having a secure roof over your head, having a good job, feeling safe in your community or your relationship. These are all protective factors for good mental health. Of course, the opposite side of that is the risk factors, the things that can harm. And they can be, for example, things like not having enough money coming in, not being safe, experiencing bullying, whether that's at school or at work, experiencing racial discrimination, and indeed discrimination on any other protected characteristic also. All these things can put stress in your life and potentially cause poor mental health. So in a sense, when we're looking at what we can do on a community level or a local government level, or indeed nationally, it's about boosting the protective factors as much as you can, trying to create well-being as much as possible, but also to tackle those risk factors to minimize them. If you look after a workplace and you have action to tackle bullying and you take bullying seriously and you treat your workers fairly, that workforce will have better mental health than if you don't care and you turn a blind eye and you allow bullying to go on and poor treatment of people at work. So again, there are ways in almost any setting where you can create good or poor mental health. Think about school. School is a remarkable place where you can create good or poor mental health, depending on the policies and the practices and the culture and the environment that you're in. Inevitably, our chances of having good or poor mental health aren't spread out equally, are they? We know that children from the poorest households are 4 times more likely than children from the wealthiest households to have poor mental health by the time they leave primary school at the age of 11. So we know that these things start early. We know people from racially minoritized communities are more likely to experience particularly severe mental illness as adults. We know LGBT plus people of all ages have a greater risk of poor mental health. And it's really important to say there's nothing inevitable about this. There's nothing about coming from one of those groups that means you inevitably have poorer mental health. But the way in which society discriminates and treats people unequally creates that greater risk. So therefore, there's things we can do as a society to reduce those risks, to equalize mental health, to make sure that we're not creating the conditions for those poorer outcomes. And of course, we know for many people who do have poorer mental health, unfortunately, mental health services are experienced less well. You get poorer access to support, less good experiences of the service, and unsurprisingly, less good outcomes from it as well. So it's really important we understand that there's a kind of continuum between the chances of having good or poor mental health and the chances of getting good support for it. And unfortunately, many people who are on the wrong end of one of those inequalities also find themselves on the wrong end of the other. It's probably time I brightened things up and talked about what makes us hopeful. Because it's really important to say none of these things are inevitable. They happen and they're widespread. And in many countries that are like the UK, you could see similar patterns. But it doesn't mean we accept it. It doesn't mean we say, oh, well, never mind. Mental health is unequally distributed and we don't create right chances for people to have good mental health in our society. We can change that. There's so much we can do at every level. And we know from the evidence that we've collected that good mental health is made in communities. It's made in homes, the neighborhoods, the schools, the workplaces, the online communities, places like this, places where people hang out, places where people identify. That's what creates good mental health. A sense of belonging, a sense of being valued, being part of something. That's where you can create good mental health. Of course, you can also create poor mental health. Communities can exclude, communities can mistreat, communities can bully. So we need to realize that communities aren't always good, but nonetheless, that's where the magic happens. That's where you can create good mental health. And we've seen some wonderful examples of local authority-led work, often with community and voluntary sector organizations that have done some fantastic work to create good mental health in those places people are. For example, supporting schools to become mentally healthier environments or workplaces or neighborhoods or faith groups. But we also know that that's supported by the structural things. You can't just focus on the very, very local because there are structural factors, as I've talked about. So we need to look, for example, about the role of local government. This is hosted by a local council today. There are loads of things local councils can do, from boosting the local economy, tackling poverty, creating safer communities, better access to public transport, improve social infrastructure, things like libraries that we know are really important to connect people with one another. And most importantly of all, perhaps, having mental health in all policies. It's the simplest thing any local council can do is whenever it's making a decision about more or less anything, I'd be interested if someone could think of a policy that doesn't affect mental health. There's a fun challenge for you. But if you have mental health in all policies, you can begin to start to make those systemic wider changes that will help more people enjoy better mental health and well-being and tackle some of those deeply, deeply entrenched inequities that cause so much distress, needless distress. Of course, it helps if that's then backed up by good mental health services. And we know that while for many people, mental health support is actually experienced very positively and is incredibly helpful and can change your life for the better, for some people, mental health services don't. They're experienced as overly coercive. Your first contact may be through police intervention, for example. We know that many people have to wait a long time for mental health support. And we know that sometimes when mental health support finally becomes available, actually it doesn't work for you, perhaps because you're autistic or you have a learning disability and the service isn't adapted properly to your needs, or it's not properly culturally competent towards your background and life experience. So we know that it doesn't always work that way, and we do need to keep boosting, not just having more mental health services, but having better and better attuned mental health services. And then, of course, it helps if national government is pointing in the right direction too. If you have national policies that impoverish people, that make the benefit system confrontational and harmful, that are increasing the prison population beyond what it can cope with, making schools places where behaviour and attendance are dealt with in a punitive rather than a helpful way, then we know national government can make things worse rather than better. And there's a really interesting now call from us and many others for a cross-government mental health plan to ensure that we really think now with a new government about how it can create good mental health across the country by creating the right conditions for that. So where do you start? By the way, you'll be relieved to know I've nearly finished and there will be lots of time for discussion. What a relief. But I thought it was important to ask, well, where do you start? Where would, let's say, Brent start? And I don't know what your starting point is. So some of these things I suggest you might be doing already, in which case, good for you. But if you're not, these are the places I think that it could be useful to start. And from our experience of working with local councils, there's always things you can learn, but there's always things you can share with others that they can learn from you too. So the first thing is to understand the mental health of your community. A really good mental health needs assessment that isn't just full of data and numbers, but is co-produced with people locally, that listens to people's voices and experience and understands what mental health is like in our place, can make a huge difference. It can help to direct very, very scarce resources into doing the things that would be most helpful. A deep spirit of co-production and co-design, working with communities, having those good relationships with voluntary sector bodies, faith bodies, any groups that can provide you access to the local community and can bring that voice into the council are bound to do good and bound to bring a richness of understanding and knowledge that you can work with and indeed support those organisations to deliver mental health support sometimes, not even having to rely on statutory services. Having mental health in all policies, I've said that's something that local councils can do and indeed national government could do. It's very simple. Just ask the question, what will this policy mean for our mental health? Not that complicated. And of course, ensuring that mental health services are brought up to date and they really are meeting people's needs and that there aren't groups of people who are missing out on support right now just because they've been overlooked or poorly served in the past. So there's lots more to be found on our website. There's way more to talk about than I've been able to try and introduce now. But I hope that's a helpful starter just to frame the conversation. Really interested in any questions, any challenges, any further thoughts or comments. I think that's enough from me.
Thank you, Andy. That was such a fantastic overview, and I can see that we've got a hand raised already. So let's dive straight in. And please do, everybody, just raise your hands or drop a question in the chat. But Francesco.
Yeah, thanks a lot, Andy. Nice one. You said at the very beginning, you're not a service provider, so you can have views about how a service will look. I go back to the 1959 Mental Health Act for myself and for my mother when ECT was compulsory, not as it is voluntary now, and for my son. But if we look at the structure of the integrated care system and their fourth strategic ambition to reduce health inequality, to improve the health of the nation, value for money, which I'm not as interested about, and, you know, improve productivity. But we've got the community mental health framework. And where I am in across the ICB, our mental health trust spans 6 local authorities. There's 6 separate discussions regarding independent mental health advocacy, independent mental capacity advocacy, and carers assessment, independent carers. So unfortunately, unlike, you know, somewhere like Somerset, Cornwall or Devon in the southwest that are co-terminus, the local authority, it does get lost in translation. But what I will say is this: since the formation of the Care Quality Commission, my mental health trust, all it's ever known in terms of assessment is require improvement. They've never dropped below it. In some areas they have, but they've never ever had they've never had good overall. So it's all very well talking, as a centre of mental health, but here's our community in North Somerset, South Gloucestershire. We've got people with lived experience, but given that there's 300 different types of diagnosis in the ICD-11, it needs to be precise. I wouldn't expect somebody that's only ever experienced or cared for somebody with social anxiety to be an expert on serious mental illness and the impact of life expectancy taking antipsychotic medication. It doesn't tally. So I think that's part of the problem. You mentioned, health inequality. King's College London, okay, through the Faculty of Nursing Midwifery, Florence Nightingale School, they've recognised three things. The researchers are very white at that faculty. The research participants are very white, and the PPI members are very white. But that, we have to remember, going back in the days, the common thing to say was, it's the usual suspect, retired white middle-aged people. But the fact is they're volunteering, and I wouldn't sort of like knock them back. But what we need is diversity. That I don't have no problem with. But it very much depends on what the plan is, and it's down to each organization. The NHS, they've shot themselves in the foot because they've got a strategic objective to actually mirror the ethnic diversity, ethnicity in England of 19%. Hey, it's actually 26% in the NHS. So, it depends on the pay band. So it can be micromanaged. It can be very difficult, but we kind of like lose sight around, premature mortality for those with a serious mental illness, and, eating disorders and emotionally unstable personality disorders somehow creeped into the definition. I'm not knocking it, but let's get real about where the definition lies. Okay, I'll stop there.
Thank you for that, Francesco. And I imagine a lot of that resonates, Andy, with the research that you do at your organisation.
It very much does, and thank you. I think it's important to hear those perspectives, and indeed the historical perspectives important, because it's very easy to repeat the same mistakes or fail to learn from what's happened previously. And I think for us, the fact that people with a serious mental illness have a life expectancy that is cut short so badly by about 15 to 20 years is symptomatic of so much more. We recently did some research, actually some peer research led by people with mental illness themselves as researchers alongside academics, which found that half of people living with a severe mental illness in this case the north of England are in food poverty. How can you be expected to live healthily if you can't even afford the basics of life? So we need to understand that this is structural as well. This isn't just about people not having access to various kind of treatments, and although it is partly to do with the medications people are given, it's not just that. So we need to understand that actually if we think about the structures that lead to this early mortality of people living with a mental illness, actually we'll deal with a lot of other things, and including the fact that there is a very strong link with deprivation and racial discrimination and all the other factors that put some people at vastly greater risk than others.
Thank you, Andy. And Abby, we'll come to you in just a moment. But I just wanted to ask, while we're on the topic of reform, obviously we've heard in the recent King's speech that the government intends to modernise the Mental Health Act. And I know this is something that you've welcomed, but I was just wondering really what it might mean practically in terms of changes that could be made for people living with poor mental health, and what you're hoping to see from that, really.
Yeah, great question. And again, this is going to play out over the next year or so, so we will see. What we are hoping for is that there was an independent review that published back in 2018. Feels like a world away, doesn't it? But it set out a series of reforms. It was a piece of work led by Sir Simon Westley, who is a psychiatrist who knows what he's talking about. And he set out a range of reforms, including things that would give patients more say over the way they're treated. For example, being able to make an advanced choice document about how you'd like to be treated if you're not able to make decisions for yourself. to choose someone to be their nominated person who will speak up for them when they're unwell, to change the conditions that someone is detained under the Mental Health Act under, to ensure that is more accurate than it is currently. So it doesn't quite tighten the conditions, but it changes the conditions that you can be sectioned. And to reduce the scope of community treatment orders. At the moment, we know that Black people are 8 to 9 times more likely to be put on a community treatment order when they leave hospital than white people. There is no good reason for that other than racism. So reducing the scope of community treatment orders, not to get rid of them, because for some people they can be valuable, they can provide stability, but to ensure they're much better controlled. So it will really kind of have better checks and balances between the individual and the state if it is enacted as the Wesley Review suggested. Now, of course, it's got to go through Parliament. We will see what happens. Debates about mental health at the moment nationally are not in the best place that they should be. And anything that's enacted may well take some time to be implemented because some of these things will cost a bit of money. So don't expect anything to happen very, very quickly.
Thank you. Abby, let's go to you.
Thank you, and thanks, Andy, for being here and speaking to us. I've been doing some work recently looking at like I guess London and about reducing improving mental health in London and reducing mental health inequalities, and have been looking at some of the research by Centre for Mental Health and around Commission for Equality and Mental Health and around the triple barrier of mental health inequalities. All been really useful. So let's do that first of all.
Thank you. Thanks.
And yeah, really helpful for framing that and thinking about it in terms of social determinants and kind of those structural things that may lead to protective factors or risk factors. And I guess I wanted to come back to something you said about ensuring that mental health is considered in all policies. So part of, I guess, what I've been thinking is if you're kind of looking at a population level and looking at how do we improve mental health, and especially kind of from a systems change or kind of structural perspective, you know, it can be easy to almost like say, well, to do that, we're going to forget about mental health and we're just going to look at housing, or we're just going to look at employment. How do you, whilst kind of saying we're going to look at housing and say that's our kind of our level, that then we know if we put a lot of investment in housing and improving those systems, that it will have a knock-on effect of improving mental health for a lot of people? How do we do that while still, I guess, keeping mental health as a focus rather than saying almost we're cracking it just by going to the social determinants, if that makes sense?
It really does make sense, and I think it's where we get greedy because we say, well, the answer is both and, of course. We want both. We've been very used as mental health organisations to taking second best and crumbs from the table. You know, mental health always being seen as the so-called Cinderella service compared to other bits of healthcare, or kind of thinking that it's kind of the thing policymakers think about when they've thought about other things and they come around to it last. So, I mean, I think it's really important to say that so much of the evidence we've got about what both creates mental health for whole communities, but also supports people with mental illness to have a fairer chance in life, is about things like housing and work and what happens in schools. We know there are hundreds, probably thousands of people in a mental health hospital now who are ready to go home, but there's no home to go to, either because ridiculously they've lost their housing status while they've been in hospital, or they need supported accommodation to kind of help with the transition back home, but no one can find any for them. And that's where you need that dual focus. So it's not about choosing one or the other. I think the other thing is there are specific interventions that there aren't many, but there are some that have been shown to improve mental health specifically. So things like parenting support programs that help new parents to know how to be positive parents to their children and manage children's behaviour. That we know that can be a really, really strong protective intervention We know that there is probably thinner evidence around some other things, but having a whole school approach to mental health within an education setting is very definitely known to support good mental health and to create the chances for that for children. For example, teaching it on the curriculum, supporting staff with their mental health and well-being, but also alongside that, providing counselling and other support for kids. So you're not having that duality between prevention and support. You're thinking actually they're two sides of a coin, and sometimes they go very, very closely together. I hope that sort of answers your question. Happy to have further conversations if that would be useful, separately to this, if that would be useful.
Yeah, I mean, it is helpful. It's ongoing point of research and trying to work my way around it. So yeah, maybe. Thanks.
Thanks, Andy, and thanks, Abby, for yeah, a great question. I was just wondering, we haven't spoken much tonight about carers, but I think that's probably another group where a lot more intervention is needed, and I'm just wondering what more we could do to support carers specifically.
Yeah, I mean, again, this is an area where it could be an hour's discussion in itself, couldn't it? Obviously, led by carers themselves, not by people like me. But and of course, there are both carers of people with mental illness and also people who have a caring responsibility whose mental health is affected by that. So that could be a carer for an older relative or a disabled child or family member. Being a carer in itself is quite a challenge to people's mental health. But we do know that many people who are carers of someone with a mental illness have an incredibly important role, which is remarkably underappreciated by statutory services. So I think it's already been mentioned by Francesco about carers assessments. People have a right, you wouldn't know it, but under the Carers Act, you have a right to an assessment as a carer. And of course, for those needs then to be met, if a need is identified, that it is met. And by and large, I think that right is ignored or put on the sidelines or conveniently forgotten. And we understand why mental health services are under enormous pressure. Social care has taken a far bigger hit financially than the NHS, but both are struggling to meet levels of need. And unfortunately, carers get sidelined and overlooked, which is a real shame, because we know that where there are models that bring in carers as equal participants, both in terms of the care for the individual, but also being supported themselves, that you get much better outcomes. It's undoubtedly very good value for public money to support carers. So I don't think this is deliberate neglect. I think there is sometimes an element of family members feeling that they're not trusted by the mental health team and the mental health service, and they're not really listened to. And that is really troubling to hear about.
And as you say, could easily be an hour's discussion in its own right, I think. Dorothy, let's bring you in.
Sorry, I couldn't find the unmute button. Andy, I thought your talk was fantastic. Thank you very much. My question is about, we're hearing a lot about the additional kind of mental health problems that Gen Z is facing, that young people today seem to be having more mental health issues. So given what you said about kind of sources of mental health problems, what do you think is going on with that age group?
That's something we're trying to make sense of. And I think it's an ongoing learning thing. And we don't know whether it's generational or age, because of course, sometimes issues are generational and sometimes they're just about being a certain age. I think what is really clear from every bit of evidence we've got is that rates of mental ill health in its broadest sense are going up among children and young people and young adults. It's particularly pronounced among young women. And again, from what evidence we got, there was a steady increase in levels of distress over the last kind of decade or so, which around about 2020 got very much worse and then stayed high. Inevitably, the first temptation is to look at technology, isn't it? Think, well, it must be social media. actually the evidence around the relationship between young people and social media is quite complex and nuanced. There are undoubtedly pressures, for example, around body image and cyberbullying that are putting pressure on young people's mental health. Though evidence around cyberbullying, for example, being bullied online, is that it tends to be an extension of bullying in person. It's not a separate phenomenon as such. I think we have to look at growing pressure in the education system, as well as some of the other things. I think we have to look at growing inequality. We know inequality creates poor mental health. The more unequal a society becomes, the higher the levels of mental ill health are observed, and you can see that internationally. And so, yeah, there are numerous explanations for it. There's clearly an extent to which the pandemic did put some very significant pressure on young people's mental health, but you can't explain it solely by that, because rates of distress were increasing prior to the start of that as well.
Thank you.
Thanks. Anita, let's go to you.
Hi, apologies, I've got my camera off in an environment where I think having a camera on will not be appropriate. I wanted to revisit the conversation on carers. I think we do carers assessments as part of my job. Like, I've done about 3 assessments today, and we offer that either as a self-assessment, or we do a separate assessment for the carer by being in with them in person. But what I found is that it's only something that goes on the council's records to know that you're a carer. It doesn't quite deal with the stress or issues that are there. There's always this temptation of one-off funds that come off, so the carers get that, or they get long-term. They choose an activity for their well-being. Now, I just think that that's really not enough, because you could have a young carer looking after a mother who's got MS, and she's giving her a lot of time. In fact, I did have a case like that, and she said, I'm not a carer, this is my mother, so I'll do it. You know, I'll do what I need to do. But I think that she needs her own space, etc. I've come across another carer who's about 10 years old. And I'm just not very sure, you know, how their mental health is being impacted. And the issues, sorry, if you hear a dog in the background, it's my dog kind of making sounds. So I think that there isn't really, I think carers are just a cheap way of not sort of investing in the care of a client, therefore the family looks after. Some people will say, well, Indian families or joint families that they support each other, so that there isn't a need for a care service for them, you know, and it carries on. So I've come across those sort of cases, and I feel very strongly, and I have done so for many years, that we ought to be doing a bit more for those who are caring for their family members, or who may have dementia, Alzheimer's, etc., because that's a lot of work. And evening care and all, and I deal with it day in, day out, because I'm coming across a lot more clients with dementia. So you always hear the carer's voice, the informal carer, but you don't have solutions to what to do. Until it gets to a stage where you have the palliative care that's involved, or end of life or something like that. That's the only time maybe there's a bit more respite. But otherwise, what about the average carer who's going to go through this role?
Thanks, Anita. And I suppose your point really touches on the workforce challenges as well, and the fact that you know, services are so overstretched that we are relying on our carers, our unpaid carers, our community services a lot more. And I wonder if that's something that you see in your role, Andy.
Yeah, thank you, Anita, for sharing that. I think it's a frustration, isn't it, that assessing someone's needs is really only getting you to the kind of beginning of the conversation. But if that's all that ever happens, or you get a little bit but not really sufficient, then it's creating promises that the system isn't then able to keep. And again, we know the reasons why. We know how local government, particularly in social services, have been left with ridiculously inadequate resources to do the work they want to do. And yeah, unfortunately, family carers are taken for granted and treated as a kind of free bit of the workforce without the kind of support that they need. We have looked at this in a number of different ways, from young carers and their experiences with school. School can be a really challenging place for a young person with a caring responsibility. They're very often not able to take part in social activities and other things that makes being at school pleasant and interesting. So there's huge challenges there. And then in later life, mental health in later life is largely taken as not of any interest to anybody. Actually, it's dreadfully neglected. And many carers are old themselves and looking after a partner or indeed an elderly parent, and others. And so again, their mental health experience is a very particular risk factor, which is very poorly looked after. We need to get real. We need to start taking this more seriously.
Ruth, your question, please.
Hello, Andy. So my question was around the mental health institutions in terms of inequality, and how much of that do you think is institutional? So it wouldn't really make a difference if you were a Black person that had a Black nurse, because of the way the institution is, you may still face a lot of discrimination. And how do you think, and what changes do you think could be made in terms of changing the institution when it comes to inequalities to make mental health more equal for everyone in terms of the treatment and that they would get in the service?
That's a brilliant question, and I think the institutional part is fundamentally important to this. We know that people's experiences of racism in society are often mirrored when they come into mental health services, and they're experiencing similar phenomena and similar inequalities. There is now a national programme which is being applied in every part of the country called the Patient and Carer Race Equality Framework. And I think that's different to any other national programme we've ever had. There haven't been many to deal with racial inequality and indeed inequity in mental health services, because it is focused on creating systemic change in local areas, much more accountability to the local community, improving the cultural competency of the workforce and the diversity of the workforce, but not stopping at that, not assuming that if you have a diverse workforce, that will solve the problem, because I think, as you've said, it will not. We know that if you look at the NHS workforce, it has a larger proportion of people from minoritized backgrounds than the population as a whole. But if you look at where those people are, there's huge and very stark differences, and particularly Black people in the NHS are still working in the less well paid and less senior positions predominantly. So there is still enormous amount of inequality that's in that system, and the institutional practices are still deeply discriminatory, and so we really do have to look at this root and branch. It won't just be dealt with just with a bit of training or slightly increasing the diversity of the workforce or any one single intervention. It really does need to be thorough. It's going to take time, and yeah, we've got a very long way to go. But I think, and of course, it's fundamentally important that organisations like ours outside the NHS work with and alongside colleagues and indeed hold the system to account for achieving those changes. And that's something that we very much hope that we can do.
And can any of that change come from government, or would it be more, it depends on that hospital, that institution, how they want to do things?
This is again where I'm going to say both. Government has to support this and get 100% behind it. the previous government seemed to be intent on denying that structural racism existed. However, they did allow the patient and carer race equality framework to get started, which is good. We need a government that's actively supporting it and gives it the resources it needs to be done properly, doesn't stop halfway through. Previous programs have just been stopped by government when they've lost interest or moved on to something else. So this will need commitment for at least a decade. But of course, it does come down to the individual institution, the mental health trusts, the social services departments, all the other bits of the system, having that commitment to learn, to change, to really change, and to not stop until we see substantial progress, so that we don't see those disproportionate bad experiences and terrible outcomes, and indeed until trust is earned. You know, it's very clear from all the research that the reason why young black men in particular do not like seeking help for their mental health is because they don't trust it, and they don't have any reason to trust it. And so until that trust is earned, then we really can't stop.
A really great question. Thank you, Ruth. And we've just got 10 minutes left, so hopefully we've got time to bring in Abby and Francesco, both of you. So Abby, if I just ask you to keep your question on the brief side, and hopefully we'll be able to bring Francesco in too.
Yeah, thank you. And thanks everyone else for your questions. Just thinking back a bit to Dorothy's question about young people, and you know, if we know that 75% of mental health problems are established by the age of 25, do you think that the increasing, I guess, number of mental health problems amongst young people means we're going to kind of have even more of a crisis in future among the wider population? And kind of related to that, should, like, in terms of thinking of a mentally healthy future as a whole, should we be focusing on children and young people more? Or yeah.
Fantastic question. Yes, I don't know, but that's certainly possible, isn't it? I mean, I think the reality is that mental health problems are so common that it will, if there's an increase, it will still just be very, very common in that age group as they age and go through their adult life and into later life. But of course, there are also things you can do at any age to turn that around and to help people to enjoy better mental health. You know, I think so we don't know what the long-term impact of that might be, but we could see an increase in poor mental health among adults as that generation goes through life. We'll have to wait and see. We'll only know as it's happening, unfortunately, but it's a reasonable assumption that it may be the case. There is a lot of evidence around the things you can do to promote mental health and well-being among children and young people, and the evidence there is stronger, partly because more research has been done, but also partly because if you can improve someone's mental health when they're 10, then you can potentially have 70 or 80 years worth of benefits to them in their life, and they're more malleable. Young brains are more prone to being influenced, if you like, and so, you know, building skills in children to look after their mental health or support the mental health of others, that's more likely to take effect. But I think it's really important we don't give up on any generation. We sometimes hear that you know, you've got 1,001 days for a small child, and while there's definitely a case for interventions in infancy, the idea that you know, after your first 3 years of life you can't do anything to promote mental health and well-being is clearly not based on any evidence, not a shred. So I don't think we should give up on any generation, including those who are now in later life. But if you are going to be putting your resources somewhere over others, you definitely focus on the younger age groups.
Thank you.
So Francesco, if we can take a very quick comment from you, and then Maureen will take a quick comment from you too, and then we can hand over to Andy for the final word.
No, just leave me out and carry on with someone that hasn't had something to say. That's fine. Thank you.
Oh, okay. Well, in that case, Maureen, over to you. Thank you.
Well, thank you for that. I spent quite a while trying to find raise my hand. I've not had that problem before. But what I wanted to ask, you started off Andy talking about co-production, and then there was discussions around people sort of working, or organisations or departments working. My understanding of it's like working in isolation. So you'll have housing, working, doing what they're doing, social care, doing what they're doing, and yet mental health should be the strand throughout. And then we've got the patients and the carers. So I was just sort of interested in your thoughts about that, because the work that I do and I'm involved in brings together all those partners. And it is quite difficult to have an equal say with the service user and the carers. The carers' agenda recently sort of increased. And I think it's good practice if we keep on sort of working to that sort of collaboration. I don't expect an answer, because we've been discussing this from sort of that fearsome report way back. But I'm glad that you talked about co-production, and we need to ensure that we have some good co-production and outcomes from that work.
Thank you. Totally agree. And I think one of the problems we have is that the power imbalance is always there. It's always big organisations, and that can include charities. But big organisations like local government or the NHS in its various different incarnations, benevolently inviting people to the table temporarily to come and be part of a conversation and then go away again. And that doesn't really shift the power dynamics. It simply kind of brings people in, consults. It's often consultation rather than actually co-production. And then that's the end of the conversation. And I think one of the things that we really want to see and encourage is a kind of permanent shift. So that kind of coming together to design services in partnership, to deliver services from user-led organisations, for example, becomes normal and routine. I think we see where there are peer support workers within mental health organisations that helps to shift the culture a bit. That where you're working with user-led organisations, particularly smaller ones, that you can start to shift the culture as long as they are securely funded and they're not kind of scratching around for bits of money here or there all the time, so that they can't ever really establish themselves. So I think this has to be a power shift, and I think that will embed it much better than the current situation, which is too often deeply patriarchal, actually.
Thank you, Andy. And thank you so much, everyone, for being here this evening and for all of your contributions. I really hate to bring us to an end, but we have reached that time. I think we could have easily gone on for another hour, happily. But yes, thank you all so much. I think it's been a really fantastic conversation. I will be circulating the recording, so if you want to go back to anything or share it with any of the people that you work with, please do go ahead. And I'll also be circulating the details for next month's event as soon as it's confirmed. So I hope you all have a lovely rest of the evening. And I'm sure that we can continue some of these conversations. So please just drop me a message if there are any points that you'd like to pick up on after the call. Thank you. Bye now, everyone.
Thank you. Bye-bye.
Take care.